Nir's talk is a nice preface for this. This is a high-intensity lifestyle intervention I'm going to describe to you. This is something that this team that's shown up here on this slide has been putting together for the last few months, working with patients and in the health system to figure out what this would be. It matches well with what Nir presented because the focus here is on African American adults with hypertension. And this team consists of some staff that are minority, but Dr. Keith is the only underrepresented minority on this team, and finding health scientists, as you all know, with that representation is difficult for the reasons that Nir presented, and I think it's definitely extremely important to this and other work, and it affects the science. The reason this is important to do is because African Americans have been way underrepresented in lifestyle interventions, both for cardiovascular risk factors, but most significantly underrepresented for studies about Alzheimer's disease and dementia, where they carried very high risk. At the bottom, Dr. Harlan, that's a typo, is at Tulane. He's a consultant on this. He runs the Goldring Center for Culinary Medicine, and I'll show you later in the talk what that is. He's going to partner with us, and then Chrissy Taney at Rush is the nutrition scientist who's been working with us on a couple of other projects as well. So I'm going to tell you why I think we need to do high-intensity interventions here. This is a focus on diet and aerobic fitness. And then I'll tell you what this is, but most of what I'm going to show you in the what part is about the food, because that's where this is really novel. Eskenazi, I presented Eskenazi leadership about 1.5 years ago, this idea that we need to do something more aggressive, and they were excited about that, but they wanted us to work with the initiatives that they're doing already in the health centers, in the FQHC, their primary care sites. And that includes some lifestyle counseling that's been there for about a decade through the Healthy Me program. That's education and counseling for weight management, and there's some exercise and support classes as part of that. There are dietitian consultations, and there are now both diabetes and hypertension self-management classes that at least a few of the FQHC sites offer. Those tend to be 4 to 6 weeks of weekly classes, and they're focused on education around nutrition and medication management. And then they have a produce program where they offer either a produce box with information about how to use the produce, or a voucher program that they have going with Safeway. Now, Eskenazi is doing things that it thinks could be sustainable financially. So these are things that can be, for the most part, reimbursed or cost relatively little to deliver. And that's something that's obviously necessary from their perspective. But from a research perspective, I'm interested in doing something that makes a splash and might cause people to start thinking differently about what is reimbursable. And so we've been doing for many, many years interventions that are pretty light, because we want them to be affordable and potentially implemented, but the outcomes tend, after all of these years, have shown to be really not where they need to be. And so impact is a product of the reach and the efficacy of an intervention. Reach is the proportion of the population at risk that participates in any given intervention, and the efficacy is the outcomes that will be achieved from that participation. And when we do sort of light footprint things that have small efficacy and then try to expand the reach of those, I think we're putting sort of it's kind of a chicken and egg problem. But I think we need to get to where we have really efficacious programs and then work on making those of high reach and scalable. At least that's one different approach to take. So this is, I'm going to orient you to what this intervention is, go back into a little bit about why now is the time to do this, and then give you more details about the intervention. But I'm mostly, when I give you the details, going to focus on the darker blue circles, which are about the food. So this intervention will mesh with the hypertension self-management program that they're doing at the FQHCs. We will have what we will call a coach go through the self-management class with the participants, and that cohort in that class will then continue on for 6 months in this intensive lifestyle program with the coach's assistance. We will do home visits for a kitchen inventory and supplies. So I'll give you a little more detail about that in a minute. We are going to have hands-on cooking classes at the centers that occur weekly. We will do 2 times a week aerobic exercise classes that we have some experience with. And Mediterranean-style foods and food deliveries will be a part of this intensive intervention. And so here I show that we will have a coach working with the participants throughout this period of time, and with Philip's assistance. There he is. Raise your hand, Philip. Philip has created some digital tools for participants to use in our other studies. And in this case, Philip's going to be working on a digital platform that the coach can use to access and manage this cohort of patients, but also through which patients would access these intensive interventions. Now the focus is on African Americans with hypertension. African Americans have among the highest hypertension rates in the world. And this is Eskenazi data. This is from another submission that we did not too long ago. And this is, I think, 40 to 60-year-old Eskenazi primary care patients. 2/3 of African Americans here have a diagnosis of hypertension. Now, Dr. Hendry, some years ago in the Indianapolis Ibadan study, did work comparing Nigerians to African Americans living in Indianapolis. And that study showed much lower rates of cardiovascular disease and lower incidence, about by half, of Alzheimer's disease and dementia in the Nigerian sample. Now, that was a cohort of Nigerians in the 90s, so they had lived most of their life on a plant-based diet and a walking lifestyle. And that was what, in this New England Journal of Medicine publication, Dr. Hendry and the team concluded was a major driver of the differences between cardiovascular disease and Alzheimer's disease. And the differences were striking. One of the papers that I was able to participate on looked at just at a few cardiovascular risk factors. One of them was body mass index. In the Nigerian sample, it was hard to find anyone obese. In the African American sample in Indianapolis, it was hard to find anyone who was not obese. The distributions almost did not overlap. So it's dramatically different. And there's been a lot of work since that time reinforcing that this may in fact be the case. The SPRINT trial was a medical intervention. It was medications to control blood pressure to systolic blood pressure to 120. And then the control arm was controlled to 140. And there were 2 JAMA publications this year showing that the result of that was lower cardio. Well, there was a New England Journal of Medicine paper a few years ago showing there was fewer CVD deaths as a result. But then this year in the JAMA papers, they showed that neurodegeneration was less, cognitive impairment was less, and then probable dementia was marginally non-significant. So there's just growing evidence that controlling these cardiovascular disease risk factors can reduce the incidence and risk of dementia. And now there have been a few lifestyle trials in African Americans, not a lot. There are, I think, 4 is what I've been able to find, aerobic fitness trials focusing, or at least with a good representation of African Americans. And there are 3 dietary intervention trials with African Americans. All 7 of those trials showed greater response to the intervention among African Americans than among the non-Hispanic whites in those samples. And in the case of, for example, the low sodium DASH trial, the African American systolic drop just from the dietary counseling and support was 13 points. And part of the reason, likely part of the reason for the greater response is that African Americans are starting at a higher level of blood pressure. Now, finally, there was a JAMA paper this year, again, that showed well over half of the hypertension disparities is related to diet and exercise, principally to a high-fat, high-sodium diet. That was over half of the incident hypertension disparity in that EPI study. All right, so this is, in my view, a fantastic time to pursue something this intensive. The U.S. Preventive Services Task Force, just about a year or 18 months ago, came out with recommendations for diet and exercise interventions in primary care, but only recommended intensive interventions. They gave no recommendations for anything that was less than intensive. By intensive, they're referring to the time and the resources that are provided. They're not thinking as intense as we are, but we'll move things along. There is NIA interest and money to do this work. Now, it is not right now difficult to get NIA approval for large budget R01s in the dementia field. But I've had a lot of conversations over the years with program officers, and the conversations I had with 2 program officers about this project was a lot more enthusiastic than the ones I've had in the past. In the past, it seems like, okay, yeah, we can do it. This, they're excited about this. This is a focus on a very underrepresented group. They're excited about this intensive intervention that they really think could make a difference. And so we, within just a few days, were on the phone and had the enthusiasm. Now, part of the reason is that we've just finished the CARB trial, and we're doing weeping is finishing analyses right now for that. And we had the aerobic intervention in that trial and had very high participation adherence in that component, and the program officers know that, so they believe we can do this, and they know that we have created this online store and that we are producing and delivering Mind Foods in the Mind Speed trial. So they believe we can do this, and they know we have a track record working with African American samples. And then finally, there's a lot of growth in meal order and delivery. You all know that in the business and world. You're probably ordering these yourselves, but healthcare is very interested in this as well. Medically tailored meals have gained a lot of traction as a potential intervention to reduce disease and costs. There's one small trial that showed reduced hospitalization and costs associated for those who receive medically tailored meals. And both Johns Hopkins and Harvard Schools of Public Health have done simulation models and shown that medically tailored meals may be as cost effective as medications. And in I think it's the Johns Hopkins one, in fact, more cost effective than hypertension medications for persons who have some food insecurity. All right, now there are some challenges to this, as I imagine you are well aware. Medication adherence among African Americans with hypertension ranges from 20 to 50% in the literature. The 20% value comes from a Medicaid population that was investigated in Maryland, and that's from medication possession ratios. So fairly low rate of medication adherence. And what we hear, we've sat in the self-management classes, and what we hear from many of the patients that are in those programs is that they do not want to take medications. Unfortunately, we also hear they do not want to exercise. And some are not interested in cooking. So there are a lot of barriers and issues to address to work through better blood pressure management. We also know from some other work we've done, actually Mike's project in the brain safety lab, we had nutrition data, and sub-analyses of that show that dietary fat and sodium are 20 to 30% higher in the African American sample there compared to non-Hispanic white. But we also know that all patients we talk to want help with the cost and management of a healthier diet. So that's the challenge at the individual level. At the community level, Forest Manor is the blue dot. That's the FQHC that Eskenazi wants us to start first working in. This is on the northeast side there. The community is surrounded by a lot of unhealthy food options. And I think the to the left side there is a Burger King, and or maybe it's a McDonald's that's not labeled on the far left. And there's a Church's Chicken. There's some full soul food shops. Maybe the fish and chicken market is good. I don't know. I haven't been there. But there are not any supermarkets. Now you have to zoom out to get to a supermarket, and then you see there's a Safeway down south, and a Manor, Walmart, and Aldi farther north across Fall Creek. Now this is fine if you have a car, but if you struggle with transportation options, this is a great challenge. And then if you step into the homes of persons living in the community, they tend to be quite small, and the kitchens are small, and there's not a lot of room to store items, so they end up on counters, and food is on counters, and there's just not much space for preparing and organizing the space. And then if you look into the refrigerators and the freezers, there are a lot of processed foods and a lot of meats. And these are two homes of participants who went through the hypertension self-management class, and our staff went in and took photos and did a kitchen inventory. And one of these homes had no produce at all. Both homes had a lot of meat. And I know there's some controversy about whether or not meat is bad, but I'm willing to say processed meats are not helpful for people with hypertension, and certainly higher fat, less lean cuts of meat are not. Cabinets, you open the cabinets, and there's a lot of items that there's just not much room, so items are stacked on top of one another and put to the back. They're not visible. Many of these items actually happen to be expired. And the tools are difficult to see, and some may not be functional, which may have something to do with why some people just don't enjoy cooking. Now, the Dietitians Response, when we brought back these photos, there was definitely, in the 24 hours after we shared these photos, there was a lot more email traffic amongst our team than there had been. And the dietitian's response was that this just feels overwhelming. The assortment of food seems random, and she felt it would be very difficult to know what dish to put together or how to put together a dish from what she was seeing here, and that some budgeting and planning would be needed. Okay, so that's some background. Now, what is this that we are proposing to do? This I'm going to show you the food components here. So as I said, we want to do, as part of this, a kitchen inventory. Now we want to do this potentially in a way that there are definitely some patients that do not want someone coming into their home. Most say they would be embarrassed. Those who don't want that most often say that it would be, they would feel embarrassed. So we want to create a checklist that could be self-administered with the coach's assistance. But we want to know, are there things in your home that you need that aren't, are there things not in your home, in your kitchen that would be needed that are not there that we can supply? And are there some things in your home that we could potentially either buy back or exchange with something healthier? We saw lard in one of the homes. If we could exchange olive oil for the lard, that would be a fantastic, simple thing to do. And then we were going to have weekly hands-on cooking classes at the FQHC, but these would be accessible remotely as well. And we will do Mediterranean-style foods through the online store. So this is going to be a low-sodium, Mediterranean-style focused food intervention. And you can see here, this on the left is what a Mediterranean-style diet would contain these foods. So lots of vegetables and seeds and olive oil and beans and nuts and lentils. Fish is fine. Poultry, eggs, and dairy is not going to be recommended, and it should be of moderate amounts. And then the meat and sweets and things. We are going to tailor this to the culture of our target population. So meat is very important. So we will be emphasizing, though, leaner cuts of meat and poultry and fish. And we will be providing either meal kits, meals, or boxes of ingredients. And persons will be learning how to use those foods and prepare them. And then we will also be providing what we call a mind food snack. So these are going to be snacks that are very high in polyphenols, which I think I have discussed with this group in the past. So it's kind of a mind diet and Mediterranean mind diet snacks and Mediterranean style meals that we will be aiming for here. So these kitchen checklists, we already have a checklist of healthy and unhealthy foods that we have used in a couple of homes. We have some more work to do. I would say this is the least developed piece of what we're trying to do. We have a list of essential tools, and then we have, we know that some space is necessary for preparation and cooking. And we really have not moved forward with what we can do about the space other than make recommendations about better storage. But there's some ergonomics to do there that will be critical. And then, as I mentioned, we'll have Mediterranean style foods that can be ordered through the online store. Philip has created this a couple of times. Eskenazi is using it now for some of their meal at home deliveries. We use it in the MindSpeed trial. It will be adapted for this one. We're aiming for fresh, not frozen. We need to provide very appealing foods to get this intervention uptake where we want it to be. So we know there's some issues with the frozen meals that are coming out. We're doing fresh meals, fresh ingredients, and our chef will be trained by the Goldring Center for Culinary Medicine that is at Tulane. This is a program that's been developed by Dr. Harlan down there. He was a chef as a young man, became a physician, and then created this program. And his real objective is to get this into medical schools. So I think he said it's in 40 medical schools now, and they're training students and fellows in how to cook so that they can be much better messengers when they're out there in the world as physicians and be good examples for their patients. He's very enthusiastic about participating in this project and having his program be the sort of teaching component of the food side of this. We will be the RD, the coach, and the dietitians, and our chef will be trained by the Tulane program, and then they will become the trainers for the weekly cooking classes at the health center. And we will be creating these mobile food carts that can be used in that. This is a version of a mobile food cart we don't quite like, so we're going to have some custom manufacturing done. And the chef and the dietitians will be, and the coach will be at this station along with patients, actually cooking, preparing, and then eating food. So there's very hands-on skills and learning here. And they will also be able to watch through video conference, and these will be recorded sessions for later viewing. They will have meal kits with recipes and instructions for the specific meal that's prepared each week at this cooking class so that they can actually have the ingredients that are needed to prepare this. Well, there's not much time. I'll take questions now, and then when we're done, I'll play this little video from the Tulane Goldring program, so you can see what it is if you have time to watch. Questions? Yes?
Have they looked at all into accommodating the various cultures of individuals that are being trained to cook? Try to more ingredients that they are familiar with?
Yes, one of my slides here has some adaptations of a Mediterranean diet that are specifically for African American. That's our focus. What they have done beyond that for other ethnicities, I couldn't speak to, but definitely adaptations for African American focus.